Good evening to everybody. I appreciate the chance to share information about stroke. So let's try to learn some things together. And I wish we had a face-to-face audience. We all lament the days before COVID. It's getting better, and let's hope the surge slows down again. But thank you all for attending. And we will be moving fairly fast, but not to confuse you, just to share the information we think is important. And we hope we'll get a chance to answer a few questions after Dr. Iyengar and I are finished. So first of all, we're going to talk about stroke as a concept and move through a variety of topics, as you'll see. May is National Stroke Awareness Month. That's our incentive to speak about this, but we should be speaking about stroke every month because it happens every month of the year. There's not a month where we ever get a break from cardiovascular disease. Our goals are to talk about primary and secondary stroke prevention and control it with risk factor management. And I'll describe what that really means. If you act fast, the acronym we commonly use for stroke, referring to your face, your arm, speech, and T for time. Act quickly when you have any symptom of a stroke. We also want to spread the news that there can be recovery from stroke, as well as some very exciting treatments that have evolved year by year. Be stroke smart. We should be stroke smart, we should be heart smart, we should be all forms of health smart. That's how we avoid illness, that's how we come to the physician with information, and that's how we prepare ourselves for a visit. But even more importantly, it's how we reduce our risk of a stroke by knowing what might lead to a stroke in the first place. If you happen to have the symptoms of a stroke, you want to recognize those, and I'll talk a little bit about what those symptoms are, as well as why is it we miss it sometimes. It's not your fault, but it's the lack of information that you may have received growing up as a child, as a young person, or as an adult. It's still a learning process to recognize the symptoms of stroke. And most importantly now, respond with a quick call to 911. Don't mess around when you think you might be having a stroke or your loved one might be having a stroke. Don't let them talk you out of it. If that spouse says, "I'll be fine, honey, it's just indigestion," that could be a heart attack. "Oh, I just feel a little dizzy, I'm probably just tired." Don't believe them. Make them go to the hospital or at least call the doctor. But we recommend 911 when there's any question, any abrupt change. It is a leading cause of death in the United States. 795,000 Americans suffer a stroke each year, about 134,000 deaths each year. From 1996 to 2006, there was a change. Stroke death rate fell 33.5%, number of deaths fell 18.4%. Some of you may know the reason why, some of you may not. I'll save it till we get to it, but something pretty critical happened in 1996, and I'll let you know what that was. Congratulations for those of you who already know. There are a lot of people who survive stroke, over 6 million. This is from a few years ago, so no doubt that's continuing to rise. A leading cause of adult disability for sure. Up to 80% of all strokes are preventable through risk factor management. That's a big number, and where that comes from is the recognition that our lifelong patterns, starting from youth, matter in the end. Our coronary arteries, our arteries to our brain, our arteries to our kidneys, to our eyes, and all of our organs are dependent upon smooth flow. And when we start with a healthy diet and maintain a healthy diet and a healthy physical lifestyle, and we don't pick up smoking, and we go to the doctor periodically to monitor for high blood pressure and diabetes, it pays off in the long run in unbelievable amounts. No one believes it, no one wants to do it. Reality is sometimes painful, but it's a simple fact that the healthier we live, the longer we live. On average, someone suffers a stroke about every 40 seconds in America. There are a lot of stroke warning signs that are not recognized, but when they are, people getting into the medical system, those of us working in heart labs and in the neurology departments are used to people coming in quite regularly. Information about women and stroke. Women have a unique situation compared to men. Sadly, stroke kills more than twice as many American women every year as breast cancer. And we think about breast cancer as being a major killer, but they're making incredible progress in preventing and treating breast cancer. Stroke, we're making progress, but still, that's an alarming statistic. More women than men die from stroke, and risk factor is higher for women due to a higher life expectancy. So age is one of the greatest risk factors for cardiovascular disease. Women live longer than men, therefore they're more likely to suffer more strokes. But there are other reasons simply beyond living longer for which women might be more likely to have strokes. They suffer greater disability after stroke than men. In the age group 45 to 54, they're experiencing a stroke surge. More and more women in this age group are having strokes. Why? More risk factors are being identified. More women are getting various problems like high blood pressure and diabetes and higher cholesterol. And sometimes they don't know about risk prevention. What about African Americans and stroke? Well, its incidence is nearly double that of the Caucasian population. African Americans suffer more extensive physical impairments, twice as likely to die from a stroke than the Caucasian population. And there's a very high incidence of risk factors for stroke that include hypertension, diabetes, obesity, smoking, and a unique genetic condition referred to as sickle cell anemia. Much of my training was in part of the country referred to as the stroke belt. That is the southeast, ranging throughout all of the classic southern cities and also including Texas. High incidence. Yes, it's epidemiologic, but also the culture there that I grew up in, you eat a lot of fried food. If it's not fried, it ain't good. So it changes your perspective, and you see a big difference when you start moving down south. For those of you from there, you know exactly what I'm talking about. In the Hispanic population, a much higher Hispanic population here than in the South, where it's much more common to have African American population. But here, also, higher incidence, higher risk factors. And one of the sad challenges is the information that isn't conveyed often in the Spanish language means that individuals who speak Spanish only have a harder time keeping up with the information. And Stroke Association, Heart Association tries to get the word out. But the only way it's going to happen is with conversations within communities. And we all know that within communities, you have a better chance of making an impact than others coming in and telling communities how they should or shouldn't act. Communities know how to act, they just need education. There are a lot of people who have strokes, and I won't read all these names, and most of you have heard of many different famous people who've had strokes. These are just examples of many famous Americans who've had strokes. What is a stroke? Some people may honestly say, if you ask me to define stroke, I'm not sure what I would say. But I'll help you understand what is a stroke. A stroke can be a blocked artery, and that's mostly what we're referring to when we refer to stroke. That's somewhere in the range of 87% of all strokes. There's some variation in that. That means that a clot has occurred within a blood vessel, blocking the flow of blood to the important tissue, in this case, the brain. The same way if you block blood flow to the heart, you are going to have a heart attack. If you block blood flow to the brain, you're going to have a stroke, and we've debated whether we ought to just be calling it a brain attack so there isn't this separate word that might be peculiar. But it's exactly the same thing. You block an artery, you have a stroke or a brain attack. The other forms are referred to as bleeding strokes or hemorrhagic strokes, and that blood can occur within the brain. That's called an intracerebral bleed within the brain, or around the brain in the space referred to as the subarachnoid space. And that's what occurs when someone has a ruptured aneurysm. Ruptured aneurysms are hemorrhagic strokes. This is a cartoon showing the difference in the left side of the slide where there is a wide open vessel, and on the right side showing what is inside a vessel that happens to have disease. That yellow stuff is referred to as atherosclerosis, and we often talk about plaquing. Plaquing is a variety of substances that include lipids and cholesterol molecules and inflammatory cells and disruption of that internal membrane that's supposed to be nice and smooth. Well, very early in life, if you have enough risk factors, you can start getting these little streaks of plaque building up in your vessels. That's a sign that you're already starting the process of deterioration of the vessel walls. It will only lead to problems, so we want to prevent that. It's much easier to prevent it than reverse it later. Stroke symptoms, here are some of the classics. A sudden severe headache, particularly the worst headache of your life. That, in our experience, would be bleeding in the brain until proven otherwise. If you show up in the emergency room and said, if I feel like I just got kicked in the head and it hurts like crazy, we're going to rush you to a CT scan, we're going to look for any bleeding, and we're going to make sure you don't have a ruptured aneurysm or some other emergent cause for that. If you can't see in one or both eyes, you could lose vision in one eye. It could be like a curtain dropping down, or you might have change in both vision where you say it's just blurry or double. That sudden onset is an indication you might have lost blood flow to a critical structure in the brain or directly to the retina. Feeling dizzy, trouble walking, sudden confusion, trouble speaking, sudden numbness, weakness in your face or your arm or your leg. The key to any symptom being particularly worrisome is the abrupt nature of it. Anytime you're suddenly experiencing something new, that's an indication you could very well be experiencing a stroke. It isn't always, but please err on the side of caution. Go ahead and call for help and get evaluated in the emergency room. We promise we will send you home if it's not, and we'll all smile about it. The stroke strikes fast concept. They do occur quickly. Part of the history we want to know when someone comes in the hospital is how quickly did it start and when were you last normal? If someone's experiencing anything that's acute, affecting the face or the arm or speech, we want you to call 911. There's something we refer to as a TIA. Sometimes people will say mini stroke. It isn't a little stroke. A TIA is the same concept of having chest pain not being a heart attack. Chest pain is a warning you might be having a heart attack in the future or in the process. A TIA is a warning that you might be having a stroke or it might stop. If it goes away and you don't have tissue damage, that by definition is a TIA, which stands for transient, which means brief. Ischemic means loss of blood flow, and A for attack. It is a big warning that up to 40% of people might have a stroke in the future who have had a TIA. Symptoms are identical. We cannot tell when you come in whether you might be having a TIA or not. All we can say is, are the symptoms still there? And if they are still there, we are going to act as if you are having a stroke. Commonly what happens is the person says, 30 minutes ago I had this event. It got back to normal. I'm here in the emergency room because I heard I ought to come in just in case. And we should say, thank you for coming in. Let's see if you're safe or not. You might be discharged home or you might come in the hospital. But that is the right call. Your greatest chance of having a stroke following a TIA is that very first 24 hours. That's the window of opportunity. Don't miss that chance for us to help discover the cause and block it from turning into a stroke. Well, what are some of the myths about stroke? Stroke is not preventable. Stroke can't be treated. It only strikes the elderly. Stroke happens in the heart. Stroke recovery ends after about 6 months. The reality is, as I was mentioning before, up to 80% of strokes are preventable. Stroke requires emergency treatment. It absolutely is an emergency. There are interventions that have changed dramatically, and you're going to hear a little bit about that in a moment. Anyone can have a stroke, from a newborn baby to a pregnant woman, to your friend, to your sister, to your brother, to your parent, or your grandparent. Anybody can have a stroke. There are many different ways it can occur. So never say, oh, he couldn't have a stroke, he's too healthy. She's too young to have a stroke. That's not possible. There are peculiar things that can occur. For example, I could simply be playing golf. I could swing, tweak my neck, tear the wall of my artery in my neck. That's called a dissection. I could say, ow, my neck hurts. Next thing I know, I could be on the ground, unable to move one side. That's an example of how weird things can happen, and they do sometimes happen. So take any new onset of a deficit seriously and get help. Think of it as a brain attack. The word stroke is fine, but it really is an attack on the brain. And stroke recovery can last a lifetime. You can keep improving. It's a myth that neurons can't reroute and come up with new pathways. It's expensive. It costs us a lot of money, $73 billion in 2010. The cost to you individually, easily over $100,000 if you go through stroke with all of the testing and rehab and other issues that may arise. How do you prevent stroke? Well, it's trying to follow guidelines. Keep reading when you're not sure. You're not going to memorize everything we say tonight, but refer back to it. Keep it as a reference and go back to the National Stroke Association, the American Heart Association, the American Stroke Association's website. Even if you do it once a year, even if you do it every 5 years, now and then remind yourself of one of the most common devastating events that can occur to you or a loved one. It's stroke. What can you do to prevent it? These are some of the things that are easy to say and hard to do, and none of us are perfect when it comes to going to the physician's office. It's not a whole lot of fun, but nowadays you can go video-wise. There's some advances that make it easier. Just do something. Even if you say, well, I don't want to go to the doctor, and I won't go to the doctor, go get yourself a blood pressure cuff and check it. And if it is consistently high on a regular basis, please seek help from somebody to make sure that it's not at a level that needs treatment. It's one of the easiest things to manage and help prevent heart attack and stroke. Find out if you have atrial fibrillation. That's a fluttering in the top chambers of the heart, and Dr. Iyengar is going to talk about that in great detail, but it is a major risk factor for stroke, extremely high risk of stroke if it goes untreated, but there are great ways to treat it now. If you smoke, please stop. It's as simple as that. If you drink alcohol, do it in moderation. Guidelines have typically said 2 normal-sized drinks for a man a day, 1 for a woman. Probably none is best. Some of the newer guidelines in Europe are saying, let's go with 0 is probably smart. Here, we say still in that range, but don't drink excessively. Don't binge drink. Protect your heart and a lot of other organs by making alcohol a small part of your life. Know about your cholesterol. You can get it screened very simply. Again, if you don't regularly go to the doctor and you don't care to go to the doctor, at least check your blood pressure, at least check your cholesterol now and then. If it's high, recognize that we have some tools that can really help to bring down cholesterol. If you have blood sugar problems, diabetes is a major problem for increasing damage to blood vessels. You want to periodically check your blood glucose, make sure you aren't developing diabetes or already have the disease. It can sneak up on you, and it's a very treatable condition. Make exercise a regular part of your life. We live here in one of the healthiest communities in the entire country and the world. We're lucky, but that's because so many people maintain a fitness regimen that keeps them very active, and it pays off for cardiovascular health. Limit your salt, limit your fat, focus on the Mediterranean-based diet, fruits and vegetables, limited red meats, limited processed sugars, and again, if you go down to Mississippi, have a nice piece of mud pie, but only have 1 piece, because it's good, I promise. Why don't people recognize and respond to stroke symptoms? Well, sometimes people don't know the symptom is a sign of a stroke. You can just deny reality. That's common enough. That's a classic male thing. We're like, it's probably nothing. We say it all the time. Think nothing can be done. That would make sense. Why would I go to the doctor? There's nothing they can do anyway. It's not true. Worrying about the cost, of course it's real. It costs a lot. It costs too much sometimes to get taken care of. But please recognize that for the most part, every institution will help you. Every institution, including ours, tries to help people who have financial limitations. Don't fail to go to the hospital because of cost. Someone will help you. People will think the symptoms will just go away. Well, sometimes they do, but if they go away, as I was saying about a TIA, your window of opportunity could be as brief as a few hours. And if you didn't go to the hospital, the next thing that could happen 3 hours later is a devastating stroke. So try to seek help. And being flat out scared and nervous, who wouldn't be? It's a terrifying thing to be ill. No one wants to think of strokes and heart attacks because they know what might come with that, but try to overcome your fear. So we can break up clots. What I was saving from 1996 was the invention and the FDA approval of tissue plasminogen activator for stroke prevention. It came out, it was controversial, the data was fairly unequivocal. It took years and years of convincing of clinicians in every field, even neurology, to start recognizing this medicine makes a difference. But it does. And the faster you go, the better at getting that TPA, clot-destroying drug in your system. You can actually remove clots by putting catheters into arteries and pulling them out. We use a variety of devices now, and those devices are extremely good in experienced hands of getting clot out of your blocked artery. Hemorrhagic strokes are the bleeding. That's if you have an aneurysm, you can clip that little aneurysm, or you can put a coil, which refers to little pieces of metal, looks like little metal filings, and you put them inside of an aneurysm, and you can seal that aneurysm off and prevent more chance of a rupture in the future. Stroke recovery, about 10% of stroke recovery is complete, 25% minor impairments, moderate to severe, and about 40%. So a lot of people live with major deficits. About 10% require skilled nursing care or long-term care facilities, and up to 15% of people will die pretty soon after they have a stroke. Therapies range from physical to occupational to language therapy and recreational therapy. But the challenges are those that affect not only you as the patient, but the caregivers. It's a lot of work to help people with daily activities, dressing and grooming and mood disorders and sexual dysfunction and all the things that make life enjoyable and pleasurable. Those can be taken away from you with stroke. So we want to help you prevent the event occurring in the first place. Lots of recovery services out there. We're fortunate to have a community of a lot of research, services, including our rehab facility. We've partnered with the University of Colorado program, and it's going extremely well at helping you to get back on your feet. The National Stroke Association, the American Stroke Association, American Heart Association, what they focus on is being advocates for patients, advocates to our communities, advocates toward a healthy lifestyle and preventing these terrible, devastating conditions through lectures like this, seminars, and websites that have tremendous information on them now. Just take the time to check them out. That's just an information on the National Stroke Association's website and a phone number that's available. All right, that's the end of my presentation. I know it's quick, it's a lot of information, but I want Dr. Iyengar to have a chance to run through his aspects of the heart, and then we will try to give you some more information through a few questions.
All right, folks. Thank you, Dr. Zacharias, for that intro and obviously going over a significant portion of the medical terminology of stroke, as well as a lot of the issues surrounding what causes stroke. Now, normally, when I would give a lecture on stroke itself, I would cover a number of the things Dr. Zacharias already spoke about. However, in the sake of time, obviously, it wouldn't be something that we want to be redundant, but rather additive. I'd like to just add to what he already spoke about and basically elaborate on a couple of the points. So with that, I'd like to start by saying stroke straight from the heart. And the reality is, I want to talk specifically on my portion of this talk on things from the heart that can cause stroke. Obviously, we were talking just about high blood pressure and carotid artery disease. These are things that are heart and vascular related, but specifically to your heart, there are certain things that can basically happen that can cause strokes to occur. So what causes strokes? Again, we did talk about this in some brevity with Dr. Zacharias' talk about the hypertension, carotid disease, but also I want to emphasize that your heart can be the source for certain clot. So if you have something called heart failure, or if you've had a heart muscle that doesn't work very well, usually we see these in patients who have had large heart attacks. you can have clot development in some of the chambers of the heart. We can see, obviously, reasons for stroke, as we mentioned, hemorrhagic, which are bleeding strokes in the brain. There's atrial fibrillation, which is called AF. That is an irregular heart rate that can actually stimulate clot formation in certain portions of your heart, which then can cause clot break-off. There's something called cryptogenic. It sounds kind of out there, but it is in that term because we really don't know when cryptogenic strokes happen what exactly is the cause. But increasingly over the last 30 years, we've found that there is a area of the heart that's congenital called a patent foramen ovale, PFO, that can serve as a nidus for clot development or transposition. And of course, high blood pressure. So I want you to look at this slide. Again, we're going to, for the sake of time, focus on the heart itself for areas of where you can get clot. So if you see what it says paradoxical emboli, that is from potentially a PFO. Your valves can get thickened with calcium or with clot, especially if it's in a low flow state. Your left atrium from atrial fibrillation or any heart tumors can cause issues with clot development. Again, your aortic valve, another valve of the heart, that if it's not opening well, can get very calcified and break off and cause strokes. And your left ventricle. So if you've had a large heart attack or you have heart failure, your heart muscle may not pump properly and thereby end up having clot development on the bottom of your heart. But again, I want to really hone in on a couple of things tonight because again, we have 50 different subjects to talk about, but I'd really like everyone to understand at least one or two concepts about heart-related strokes, and one of them is atrial fibrillation. You know, I do a talk for atrial fibrillation with my electrophysiology colleagues, and we fill up an hour and a half just on atrial fibrillation. So you've got to imagine how much information I need to present here to kind of give you a little background here, because AFib can be talked about all day long. What it is an irregular heart rhythm. Basically, the top part of the heart, the atria, don't communicate electrically with the bottom, which are the ventricles. It results in symptoms of shortness of breath, lightheadedness, and palpitation. So this is when people complain and say, you know, I just feel like my heart's jumping all over the place. It doesn't feel right. And of course, everyone seems to have an Apple Watch now, and they all seem to get these monitors where they see, oh my God, it says I'm in AFib. That's great, actually, because it tells us before an event happens, maybe we can identify the cause of it. But I hate to say it, I have hundreds of patients who have atrial fibrillation and don't feel a thing. They have no idea they have an irregular heart rate. They just feel like they do normally. So what causes AFib? Get this question a lot. High blood pressure, prior heart attacks, which is from coronary artery disease. If you have abnormal heart valves, thickening of the valves where opening or leaking can cause it. You could be born with heart defects. An overactive thyroid gland or underactive thyroid gland. Excessive exposure to caffeine, tobacco, or alcohol. The big one here is alcohol. Alcohol can definitely stimulate arrhythmias, and AFib is seen quite commonly in heavy drinkers, even in individuals who basically we call it holiday heart. People who come in on New Year's Day after having a great night on New Year's Eve can have a significant amount of alcohol inducing an arrhythmia, and it can be atrial fibrillation. An additional one that I don't have here is sleep apnea. If you have sleep apnea and you snore at night, over time, that can make your chambers of your heart work harder and stimulate AFib. So how do you diagnose it? You don't diagnose it by saying I have palpitations, because palpitations can be caused by a bunch of different heart rhythms that are not AFib. You need an EKG or an ECG is mandatory. Not every irregular heart rhythm is AFib. PVCs, APCs, skipped heartbeats, these are all other terms for benign heart rhythms which do not cause stroke. AF does not have to be chronic. It can be short-lasting or it can come and go. We call that paroxysmal AF or PAF. So how do you treat AFib? We use medications first and foremost. We try to get you on something called beta blockers or calcium channel blockers if you're symptomatic. We add antiarrhythmic medications to control your heart rhythm if these first medications don't work. We perform a cardioversion, which is electrical stimulation to convert you back over to your normal rhythm if you're still symptomatic despite medications. And ablation, whether surgical or percutaneous, which is through your groin, can be done if your symptoms are intractable. So this is how you treat AFib, the rhythm. But this doesn't mean we're treating AFib, the complications. Because what AFib can cause? Stroke. There is something called the left atrial appendage, which is in the left atrium of your heart. You've never felt it. I've never felt mine. It's one of those situations where it's an almost inert part of your heart that may have been there hundreds of millions of years ago when we came out of the water. It's like your appendix. Nowadays, these areas only serve to cause trouble. So when people who have AFib go on a blood thinner, and I think you've all seen the commercials on TV because they're always on, the reason is that when someone's in AFib, the top chamber doesn't squeeze normally, and blood swirls in the chamber. And where does swirling blood end up? In the little pocket called the left atrial appendage, where over time it coagulates and becomes clot. Hence why we place every AFib patient on a blood thinner if their risk score is elevated. And blood thinners work very well, but the problem is you got to take it. You can't take 2 pills one day and none the next day thinking you've doubled up. That doesn't work. Warfarin or Coumadin, dirt cheap, but people hate taking it because of the dietary restrictions and as well as issues with testing. The NOACs or DOACs as they're called, the Eliquis, Xarelto, Pradaxa, you guys see in the commercials, are costly, but they lack readily reversible agents. And again, compliance is tough when patients feel like, well, I don't want to take a twice-a-day medication. I don't want to take it every day. It's difficult because these medications have a fixed window of time span of working. And all of the above can make bleeding worse. But I want to emphasize, if you can take a blood thinner, you should, if you have atrial fibrillation and an elevated risk of stroke. There is where these medications work. So there's no excuse for not being on a blood thinner if you have the elevated stroke risk and have AFib. If you have reasons not to take a blood thinner, well, then we can continue the conversation. But first, we have to identify that AF is a growing problem associated with a greater morbidity and mortality, and it's a higher stroke risk for older patients and those with prior stroke or TIA. Nearly 20% of all strokes are related to atrial fibrillation. They are very debilitating. As Dr. Zacharias mentioned, these strokes are usually, or if not always, ischemic in nature, as in a blood clot breaks off from the heart or somewhere in the body and goes to the brain and causing an ischemic stroke. What happens when you take blood thinners later in the process of being in AFib, usually those strokes can be related to bleeds in the brain because maybe a blood thinner is what you're on and you've had a small little hemorrhage in your brain which gets worse with the blood thinner. So that's why we like to point out that being on blood thinners carries some risk. So we always want to be careful that we don't put everybody on a blood thinner with AFib, but rather your doctor and yourself will talk about what your stroke risk is and the pros and cons of being on a blood thinner. This is a score that we utilize in every patient that comes in with atrial fibrillation. It's called a CHADS Vas Score, and basically you can see it there. It relates to your age, history of heart failure, history of high blood pressure, diabetes, prior stroke. We use this score and add up a number to come with your stroke risk. To be honest though, right now the guidelines are really strict. They're actually stating for patients who have a score of 1 or greater, we should consider a blood thinner like Coumadin or Eliquis for every patient. Unless your score is 0, those are the only patients we are not safe, but rather are told that you can basically use an aspirin a day versus a potent blood thinner. So again, we talked about warfarin, which is Coumadin. A lot of patients take it, but as you see there in that scale, we have to be very careful. You need to keep your INR, which is your Coumadin level, which many of you may check, between 2 and 3 to keep it therapeutic. If it's less than 2, you have a risk of stroke. If you have a score of 3 or higher, you have a risk of bleeding, which could transform into a bleeding stroke. So the challenges are keeping patients on these medications. I will tell you, I have a lot of patients who say they won't take the rat poison Coumadin, and they say, I want to take the new medications. Well, guess what? Once they see the insurance bill or once they find out that they can't come off it, a lot of patients get hesitant about staying on these medications. So again, to reiterate specifically about atrial fibrillation, there's a number of causes for AFib, And once they are identified, and I think our screen just went, but I'll keep talking and just let you know that once you have, there's a number of issues associated with AFib, including, like I said, high blood pressure, sleep apnea, alcohol use. Those can be curbed. But if you are diagnosed with AFib, it's a boomerang. It can come back. So if that's the situation, we want to treat you appropriately and control the symptoms, but we also want to make sure you don't have a stroke. So if you have the CHADS Vas Score that's elevated and you have AFib, being on a blood thinner is heavily suggested, if not mandatory, to prevent potentially a stroke in the future. Now, with that being said, I just want to show you a video of something that we do currently for patients who cannot take blood thinners. This is called the Watchman Device. This device is for patients who cannot tolerate blood thinners but who have AFib or PAF and have an elevated stroke risk, so they need to be protected. So this device goes through the vein in the groin region and goes to the heart through a catheter. We then make a small, tiny puncture from the right to the left side. It is not felt by the patient. We then cross over to the left side, place a catheter or wire into the area of the left atrium, replace it with what's called the Watchman sheath, and then we place something called a pigtail catheter into the left atrial appendage. This is the morphology, and these are all different shapes of how the left atrial appendage may look. We place a catheter into the appendage, measure where we're at, as well as the depth, inject some contrast to really measure again what we looked at. Once we have the measurement, we can then have a better idea of what size device we want to put in. And once we decide the size, we will put in what's called the Watchman Flex. We basically advance something called a ball into the area, and if we don't like the position of this, we will actually re-advance and place this again into the appendage and reposition it. It's very soft, so it doesn't cause trauma to the walls of the appendage. And then once we redeploy this, if we're happy, we will then go through our criteria to see if it looks like it's sitting properly. And if it is sitting properly, and this is called a Tug Test because we're pulling back on the device to make sure it sits in place. And then we evaluate the size based on our sizing charts for every device that's placed per anatomy. And we look for any type of color that may be surrounding the device as well. And then in that case, we go ahead and release the device. And there's anchors that keep the device in place so it does not move. And the device has shown to be very steady over time. And as we see right here, the body absorbs the device over time. So what we have found with the Watchman device, there's significant changes in improvement in patients not having bleeding issues. So for patients who cannot tolerate blood thinners, this is becoming a viable option for patients. So there are therapies for patients who are watching right now who say, fine, I have AFib, I guess I'll go on the blood thinner, but I really have a history of GI bleeding or I fall. These are the indications to perform and utilize this device. Studies have shown significant reduction superior to standard blood thinning medications. And our patient population, the ones that I offer this therapy to, patients with AFib, patients with an elevated risk of stroke, and a reason not to be on a blood thinner, as in bleeding, history, falls, some type of lifestyle that basically says you cannot take a blood thinner. If you're doing something outdoors with sharp objects and any cut or bleed could be life-threatening, these are the things that we talk about for this device. For the sake of time, I want to focus on a second part of the heart, another area that may cause strokes. This is called a patent foramen ovale, a PFO. A PFO is a persistent flap-like opening between the atrial septum primum and secundum at the location of the fossa ovalis. In creation in utero, the foramen ovale serves as a physiologic conduit for shunting in the heart. After we're all born, most of us, the establishment of pulmonary circulation, the increased left atrial blood flow and pressure results in closure of the PFO. This functional closure is subsequently followed by anatomical closure of the septum primum and septum secundum. But I want to point out, before I look at this anatomical graph, 20 to 25% of the human race still has a PFO, as in there is 1 out of 5 people walking right now who has a small PFO potentially that doesn't know it. The reason is because sometimes they don't close. That's okay, because again, it's just another part of the heart which is from congenital era that doesn't really cause problems in the vast majority of the patients. However, in the last 30 years, we've found there's been association with PFO and stroke. We found that the prevalence of PFO in the general population, again, ranges up to 25%, so we'll say 20%. But in patients with cryptogenic stroke, the prevalence of a PFO was nearly up to 60%. So evidence is mounting to seek a better alternative than just prescribing antiplatelet medications. And data has been showing in patients who have a stroke, and a PFO is the only source that we can potentially find, that putting a closure device across that PFO is actually better than antiplatelet medications like aspirin. We don't have evidence so far, though, that Coumadin or Eliquis or those medications are inferior, equal, or better than the PFO closure. However, we do know now that there's more evidence that if someone is young, has a stroke, and has a PFO, rather than lifelong aspirin or Plavix, closing the PFO will actually result in less morbidity over time. So again, a cryptogenic stroke defined as a cerebral ischemia of obscure or unknown origin. The cause of a CS, which is cryptogenic stroke, remains undetermined because the event is transitory or reversible. Investigations do not look for all causes, or because some causes are unknown. And 1/3 of ischemic strokes are cryptogenic. So how many happen? Nearly 700,000 per year. 80 to 85 of them are ischemic. 40 to 60% of the PFOs among cryptogenic strokes, and 100,000 strokes per year where the PFO is the only identified potential etiology. So there's a lot of this happening. So why are we closing every single patient with a PFO? Because even though there's a lot of numbers here, they're still extremely tiny compared to the amount of people who have a PFO in population. So I would say if you have a PFO and you're watching this right now, do not rush off to your cardiologist or neurologist if there's been no history of any neurologic issues. To be honest, the PFO is one of those things we see all the time, and the only rationale to close it is if there was associated neurologic event and there is no other reason to explain that neurologic event. So what is the mechanism? Some people think the pressure in one side of the heart to the other occurs because of increased pressure in the chest. So if you're valsalving or bearing down or coughing, or you have high pressure in your lungs, that can cause shunting between the clot between the right and the left side. Decompression sickness, diving, is thought to be a way of shunting blood from one side to the other and may cause clot movement. So if clot goes from the right side of the heart to the left, why does that cause a stroke? Just like an AFib, the left atrium communicates with the left ventricle, which communicates with the aorta, which goes to the carotid arteries of the neck. So it's basically going through a doorway and up a channel to the brain. So again, studies in the past to close PFOs really hadn't shown a major benefit, but we saw a lot of signals with using devices to close PFOs. Recently, or not recently, but in the last 10 years, we've seen increasing, basically, I would say high quality studies being performed that have now shown increasing data to say if we do close these PFOs, we can reduce the number of stroke events, and it's actually measurably better than just aspirin alone. So these studies, again, we're looking at a number of follow-ups for the patients. We're looking at the non-fatal stroke, the TIAs. Again, even though percutaneous closure does not reduce the risk of subsequent events, the truth of the matter is that we're seeing a signal that these devices can be beneficial. We see here from Dr. Carroll, closure of PFOs versus medical therapy. So what we're seeing, there may not have been a significant benefit with the closure initially, but again, the signals indicate that these are moving in the right direction with these closure devices. And again, the conclusion here, the percutaneous PFO closure did not prevent recurrent stroke, although secondary analysis suggests possible efficacy. This was followed by an additional trial, seeing that, again, we're comparing these PFOs versus antiplatelets or anticoagulation. What was the conclusion of this trial? Amongst patients 16 to 60 years of age who had a recent stroke attributed to a PFO with an associated septal aneurysm, the rate of stroke was lower with PFO closure plus long-term antiplatelet versus aspirin alone or antiplatelet alone. So we finally have gotten data that's really strengthening what we've been thinking for decades. But the good thing is, it took us time to really find out which patients benefit. And now we're seeing different devices come out, which are showing that, again, if you use Gore's device, which is utilized in this trial, you can see that silent brain infarctions or incidence of new brain infarctions were less with PFO closure. And this is the timeline. If you look at the year 2000, it just started. All of these devices started coming out for closing the PFO as in widespread utilization. We're now well past 20 years of utilization of these devices, and wow, we are now finally seeing FDA approval of these occlusion devices, which was in 2017, and finally acceptance that, hey, this device works in the right patients. Again, this is just a schematic of how the device looks, and I'm going to go ahead and show you a video of what a PFO closure looks like. So once again, we're in the heart, and these are just little clot debris. And see that little clot that went across? That was the PFO that went across. And now it's in the left ventricle and goes out the heart and goes into the carotid artery and causes an ischemic stroke. So basically, the FDA approved the Amplature PFO occlusion device. This is one we utilize quite regularly. This is the device that actually will go across that PFO and sit there to occlude it. So once again, we will go through a vein in the groin. We will go up to the heart and cross the PFO. So we're not making a puncture. We're crossing a hole that's there. Once we've crossed that PFO, we then open up one side of the disc of the PFO occlusion device. And on the other side of the heart, we release the other side, like a sandwich. It's like a hamburger bun across the septum. And once released, it sits in place, and it's a permanent structure and prevents blood from going from one side of the heart to the other, thereby preventing stroke from occurring. So where do we go now? Whenever a patient comes to me who has had a history of stroke, we do the full workup. We talk about the history, the physical. Because I can tell you right now, I've had a lot of patients that come to me who say, I had a stroke, I've been told I have a PFO, I need you to close it. And I will look at that patient and say, ma'am, you're 80 years old. I don't think your PFO caused your stroke. And the reason, and I'm not saying that in jest, but it's because at 80 years old, the likelihood of a congenital hole causing a stroke is extremely low. Most likely at that age, your arteries, your neck, your aorta with plaque, your AFib potentially, if you have it or not been diagnosed, those are more likely. If you're 20 years old and unfortunately had a stroke, I'm going to say we got to look for a PFO. Because a 20-year-old likelihood of a plaque or a AFib event, much lower. Not impossible. And like Dr. Zacharias mentioned, we have patients that have torn arteries, young patients with carotid dissection. So there's always the gamut. You have to look at every part of the patient prior to jumping and saying, oh, you have a PFO? Let's close it. Oh, you have AFib? Let's just put the Watchman in if you can't take a blood thinner. We need to take a step back and say, what caused the stroke? Could it be something as unsexy as hypertension? You have high blood pressure. Control the pressure, we'll be okay. We'll do better in the future. Could it be something like sleep apnea or alcohol use? These are all common causes of cardiovascular risk of stroke. So it's important that we take the whole picture. And I will tell you, first and foremost, I work with Dr. Zacharias one-on-one with a lot of these patients. If a patient comes and asks for certain things to be done, well, I'll say, if you have a stroke, well, I want a neurologist to be involved with the decision-making of how we go forward and how we decide about procedurals if you need them or you don't. So future directions, there's a lot of trials going on right now with blood thinning therapies, a lot of trials compared to closures versus Watchman, but again, basic. Blood pressure, stop smoking, curb your alcohol if you can't eliminate it, obviously sleep apnea. If there is a stroke that's already occurred, let's look for the common causes based on your background. Let's not jump and say you have a hole in the heart, close it. That's not the right answer. The right answer is finding out what caused that event for you, not necessarily what, again, we think may be happening. So conclusions, stroke can happen from a number of different avenues. It's exciting to see future technologies develop, but I feel the technology that I've shown tonight is only additive to what you and your doctor need to talk about in the office, or what we would talk about in the office. These procedures are not the first line therapy. Rather, they're after we make the diagnosis. Thank you very much.
Thank you very much, Dr. Iyengar, and we're going to also bring up Dr. Zacharias and field a few questions before we end this tonight at around 8 o'clock. I'm going to go through these just randomly here. One of the people who was watching tonight said, after a stroke, our brain can rewire for aphasia recovery and physical deficits. Can our brains also recover, rewire from loss of emotions?
Sure. So any neurologic process, whether it's emotional experience, processing of information, processing, understanding, or expressing language, can be retrained. And it's true that the younger we are, the more so-called plasticity we have, the greater chance we have of rewiring occurring. But at no point, at no age, are you unable to potentially improve. There are a lot of variations as to what determines whether you will, but yes, absolutely, and with really well-trained therapists, physical therapists, occupational therapists, speech-language pathologists, they're very good at dealing with recovery techniques.
Okay. If you have high cholesterol but low coronary calcium scoring risk, are statins required?
So the question is, if you have high cholesterol, high LDL, I assume, but low calcium score. Remember when people say to me, I have a low calcium score, so what if my LDL is 200? Because, I mean, the calcium score is low. And I always tell them, your score is low now. That has no bearing in the future. If you let your LDL basically continue at this level, you will potentially accumulate atherosclerotic plaque, if not soft plaque, under the vessel itself, which could cause a heart attack. That's why we're so aggressive about treating it. If your calcium score is 0 and you still have an LDL that's high, I would still treat it because of the future risks that we are associated with high LDLs that are not treated with diet. If you can't treat it with diet, then I would absolutely discuss medications.
Okay. This person heard that 1 glass of water before bed and 2 upon wakening can drastically reduce stroke. Is that true?
I don't know, is my honest answer. And please type in a reference and I'll be happy to look at it later.
Okay. Does the de-emphasis on aspirin as an anticoagulant mean it's not recommending aspirin for the elderly?
So from the newest guidelines came out, and they're basically been stating that aspirin for primary prevention, preventing a first event, is not suggested in a lot of people if you obviously don't have risk factors. However, I always tell my patients, if you have a history of any stroke, vascular disease, carotid disease, heart disease, then you are in that category where baby aspirin can be beneficial. If you're someone who's not had any of these risk factors and you're saying, well, I'm taking a baby aspirin to prevent an issue, that's where the guidelines have changed. They're saying that aspirin can cause GI issues in the stomach and kidney issues. Hence, we don't tell everybody to take it anymore. Remember that commercial, I take one of these to prevent a heart attack, the Bayer aspirin? No, we're saying that's not indicated. However, if there are risk factors like I just mentioned, vascular disease, stroke, prior heart attack, heart disease, baby aspirin is absolutely adequate.
What is the best device for checking blood pressure?
A blood pressure cuff. I mean, honestly, there is no doubt when people come to me all the time in the office and they bring their blood pressure cuffs in, I would say checking your blood pressure cuff to your doctor's office, number one, is very important. Number two, wrist cuffs just don't measure things as well than a traditional arm cuff. So get one that fits your arm properly, because there are obviously different sized arms, there are different sized cuffs. Second, or third here, check in both arms what your blood pressure is, because sometimes with people with vascular disease, we'll have different blood pressure readings in each arm. So check them in both arms, calibrate your cuff according to your doctor's office, and get a cuff that fits.
We're going to squeeze in a couple more questions here. Eye stroke is caused by not enough blood supply to the brain and eye. Is that true?
Say that again.
Is eye stroke caused by not enough blood supply in the brain and eye?
I think, yes. I think that's what they're getting at. So if you lose vision in the eye, classically that's caused by a blood clot. Most commonly, a piece of plaque breaks off from the carotid artery, and the first branch of the internal carotid artery is called your ophthalmic artery, and it often sneaks in there. There are rare exceptions. There are cases you can have a stroke to the eye during surgery, for example. If you're lying in a prone position and your head is under pressure, that can lead to dangerous loss of blood flow to the eye. So there are ways you can lose blood pressure and have a stroke to the eye as well.
Okay. One last question. Is there a test to find out if you have plaque and where that might be in the body?
So, you know what? Normally, if a patient has an indication for a carotid ultrasound, usually, insurance companies are variable whether they approve them or not. But oftentimes, getting a carotid ultrasound is a painless, easy way to check if plaque is present in the arteries of the neck. If you have any issues with your legs having pain, checking something called an ankle brachial index, very simple, easy test to do as well. Oftentimes with the heart, it's a little bit harder to say if there's plaque. A coronary artery calcium score is a very common test utilized. A lot of patients like doing it. It's simple. Again, though, once the data is back, the question then is patients don't like the answer. If they see a calcium score that's over 0, the first answer you're going to hear from a cardiologist is, well, we're going to probably think about a baby aspirin and a cholesterol-lowering medication. And so a lot of patients tend to be like, they want the information, but they don't necessarily want the treatment. So I oftentimes say, if you want to look for these things, these are the things that your doctor most likely will respond to if they find something.
Okay, great, thank you. Thank you to Dr. Iyengar and to Dr. Zacharias. Thank you very much. We've come to the end of our time. A recording of tonight's lecture is available at bch.org/livestream. You will receive a post-lecture survey by email. Please take a minute to fill this out. Thank you for joining us and have a good night.